the smell of an oily rag and have a bunch of volunteers. And so you've ended up with me again. Welcome to the last stream of the afternoon. This one is hopefully you want to be in Stream C, which is talking about health and applied work with health data. We have lots of interesting talks, including one from me and Daniel. But we'll start off by inviting Caralyn. Is she here? Yeah, great. So Caralyn Purvis is going to talk to us about adopting an improvement science approach to informing ongoing implementation of the Manaaki initiative in Canterbury. So is there a timer on the screen? No, okay, I'll give you a little wave. Okay, cool, great.
There we go. Tēnā koutou katoa. Thank you, and thanks for the opportunity to share some of the work that we're doing down in Aotearoa, Christchurch. So I'm the evaluation lead on an initiative called Manaaki, Stronger for Tomorrow, and it's based within the Canterbury District Health Board and funded through the Ministry of Health. So I'll give you a snapshot of one element of that today. So the problem or challenge per se that I'm describing is one that we all know too well, an increase in the prevalence of mental health and well-being concerns. It's been seen internationally, but very much so here in Aotearoa, New Zealand, and even more so for our tamariki and rangatahi, where the ongoing pressures of society and the world are ever increasing. And even more so in Waitaha, Canterbury. We've had a number of challenges over the past 10 plus years that just continue to come. So in response to this, an initiative called Manaaki, Stronger for Tomorrow, was implemented in 2018. It's an initiative that provides well-being and positive mental health support for tamariki in primary schools aged years 1 to 8. So in itself, it's quite broad. I could probably spend a good amount of time just describing what the initiative is itself. But the key things to know are that it was implemented at speed. It provides universal and targeted support for mental health. It's an early intervention holistic approach for tamariki, whānau, schools, and looking at community as well. So all of these things make it unique and really adaptive and flexible and responsive to the needs of the community. But in my role as an evaluator, when asked to evaluate an initiative like that, it's also what makes it incredibly difficult. So in response to this, it's important to highlight here that in health, as many of you will know, it's pretty unusual to have an evaluation that sits alongside concurrently running in addition as the service is implemented. So acknowledge that my position was relatively unique, and I'm grateful for that. But that also posed a challenge in that many service improvement kind of evaluation looks summatively, and audit tends to look at just a point in time. So I've used the term improvement science to describe what I do, because not only were we looking at measurement and looking at optimizing the benefits of making change and iterative improvement as we go, we were also looking at how to share and encourage learnings from that. So an example of that is we provide data dashboards to the schools that we work with and encourage them to be curious about the data and the tamariki and requests for support that they're putting through. So what does that look like in practice? So this is my world. So the design, especially the initial design, was incredibly quick, and it's an ongoing collaborative design as we revisit it. We implement the intervention. So as I said, it goes from community support through to school support, whole class, through to small group work, and through to individuals. And we have data points at each of these levels. So that looks quite far and wide, mixed methods approach, lots of qualitative data and quantitative data, and then connecting with wider data sources. So the data collection is quite vast, as I mentioned, and constantly looking at ways that we can connect in with what exists rather than putting additional data burdens onto people. So evaluation, this is a brief snapshot of our evaluation framework. But essentially, we're looking at evaluating impact and looking at service improvement across each of these domains. looking at tamariki at the centre, whānau, and going out to challenging how the system is designed or not designed to meet the needs of our communities. So then the last step is refinement, and that's been an iterative refinement approach as we go. And as I say, it's relatively unique that we've had the luxury of doing that and making those small adaptations to meet the needs and throw it back into practice so that we can make those quick changes. So that's a very brief snapshot, but in terms of learnings, so I think there's been a real, as I say, recognize my uniqueness in the position of evaluation as we go. But I think there's a real value in that we can make those adaptations based on the data, based on the research and literature that we know, and rather than waiting until a certain point in time to make those refinements, we can ensure that we're meeting everyone's needs as best as possible. It's been a pretty agile approach. We started out with a relatively small concept, and now our design looks very different to how it did in the beginning. So the idea of improvement science aligns with that type of approach. We've been able to determine what works for whom and in what contexts, again, because of this unique approach. And our mantra with Manaake is we're flexible and responsive. And again, I think that having this kind of approach has allowed the evaluation to align with the initiative itself. I'm not sure how I'm doing for time, but so also in terms of my next steps, we've got a unique opportunity because we sit across health and education, but we also intersect with the social sector. So we do have a relatively robust amount of data that we're going to look at exploring from a connectedness data sharing across sectors. And so that's my next challenge. Keen to talk to anyone who has any advice or guidance in that area. Kia ora, that's me.
Thank you very much, Caralyn. Time for one quick question. Carolyn's details are up there if you'd like to follow up. Any?
Can you give some examples of what those iterative changes are? Like the really small things? Would you like me to say that again?
So some of the small changes that we were making as we go. So ways that we capture data, ways that we measure our outcomes, I guess. So it's in the context of child wellbeing, there are very few outcome measurement tools that we use. So we implemented one at the beginning and then we recognized that it didn't really capture the child's voice in that. So we added in a couple of other aspects that captured that. Things like adapting our client management system, because what we thought we needed at the beginning is not what we need now. And things like data security and capturing data about people, I guess as Kylie was talking about this morning. We initially started out capturing all data about our clients, client management system, about a tamariki that we work with, but then recognizing that actually for those lower level interventions, thinking about data storage, that was a real barrier to some people wanting to access the support. They didn't want data to be held about them. So thinking about ways that we can change that in practice as well. So it's a really close link between data evaluation and what we see on the ground. Thank you.
Thank you very much. Thank you, Carolyn.
Thanks.
Right, next up we have Gabrielle Davie. Talking about linked data is vital, evaluating the impact of pre-hospital care on mortality, major trauma. Gabrielle's from the University of Otago, but also she's a really key member of the Virtual Health Information Network Executive. Gabrielle.
With a G.
Oh, that's interesting. Yeah.
No, it's all good. Kia ora. So the recent availability of routinely collected data on pre-hospital care, otherwise known as emergency medical services or EMS care, is what's made this innovative applied linked data project possible. As a bit of background, we know the potentially fatal or severe consequences of many injuries can be reduced through an optimally structured pre-hospital trauma system that can provide both timely and appropriate care. The aim of this project is to investigate how EMS care impacts on mortality, or ideally survival, for major trauma cases, and in doing so, help identify opportunities to optimise the delivery of EMS care in New Zealand. Just explaining the logo, so this research is funded by the Health Research Council of New Zealand. I'm from the University of Otago, as Andrew said, but the principal investigator is from the University of Auckland. Now, time is an important determinant of trauma outcomes, so the first research question is focusing on time spent in the pre-hospital setting. So that's the occurring before or during transportation stage. So the EMS data is fantastic in that it captures the activation time, response time, the on-scene time, and the transport time. So we're looking at the contributions of all of those components to the total pre-hospital time, and then the relationship between that and the outcome survival to hospital. The second research question is more focused on the EMS care received. So after adjusting for case mix differences, what is the relationship between the type of EMS care received? So for example, advanced life support with multiple interventions versus basic life support, the destination hospital, so were they transferred directly to an advanced level hospital or were they bumped up via regional hospitals, and survival to hospital, the outcome. So to answer these questions, we're using a retrospectively designed prospective cohort study, or in non-epidemiological speak. So that's we're identifying a group of people that meet eligibility criteria and looking at their outcomes at a later date. So there's three main phases to this project. I'll cover the first phase on the next slide. The second phase, which is where we're at now, we're describing the pathways and processes of care, and we'll undertake multivariable statistical modelling as part of that. And then the final phase will involve assessing the implications of the findings through workshops with key stakeholders. So talking you through this slide, identifying the cohort and assembling the data set has been epic. It's kind of one of those situations where you think, so maybe this is why no one's done it before. So St John covers 90% of the New Zealand population, with the remaining covered by Wellington free ambulances. They were mainly on an electronic system, but we did have some paper coding to do with some of the Wellington free data. But from within the data set, we selected trauma cases. So those are cases with physical injuries only. So we exclude, that typically excludes poisonings, hangings and drownings. So there are about 250,000 EMS trauma cases in the 2-year period that we looked at, from December 2016 to November 2018. As we're only interested in serious trauma, we restricted the data set to those that experienced major trauma or that died in the pre-hospital setting. For those that died pre-hospitally, we obtained information via the post-mortem reports that are collected by the National Coronial Information System. And EMS cases that met the National Trauma Network's definition for major trauma were retained with information obtained from the Major Trauma Registry. The final cohort includes 3,352 people, 70% male, 21% Māori, which obviously is not representative of the population, but for those that work in injury, that's what we would expect. And then we've also obtained Ministry of Health data and linked that in, so that's mortality collection, hospital discharge data, and information from the NHI database, because that gives us more up-to-date and gold standard information on key fields. If you want to know more, this is our protocol paper, was published in Injury Prevention, so feel free to read that or email me. When I say our protocol paper, here's where I acknowledge the awesome multi-site, multidisciplinary team that's needed for this type of research. Project lead is Associate Professor Bridget Cool, who's an injury epidemiologist with a background as a paediatric surgical nurse. Others in the team have roles such as the clinical leader of the National Trauma Network, head of audit and research for St John. And in addition to team members with data science and biostatistical expertise, we're also fortunate to have the involvement of professors in Māori health, surgery, paramedicine, public health and epidemiology. The team's also well supported by a study advisory group that includes a coroner, emergency medicine specialists, as well as representatives from NASO, which is the National Ambulance Sector Office. Is that my 5 minutes? The Fire Service and ACC. So over the next 12 months, we plan to have a number of results publications out. So if you're interested, keep an eye out and keep in touch. Thank you.
Quick question for Gabrielle with C.
No.
Question for me then is, you're doing the data linkage.
Yes.
Yes. So where's
Done.
that happening?
Where?
Yeah, in terms of what environment is the data linkage happening?
That's a good question. Happening at the University of Otago.
Yeah. Okay. So that you bring the data and you're not playing in the IDI, you're just bringing it
No.
in separately. Yep.
No,
Cool.
so St John data, a number of those data sets aren't actually available in the IDI,
Yeah, so
and
you're not
I
doing
believe.
an ad hoc load or anything silly like that.
No, I heard that there was quite a delay on that.
Yeah, 2 years, you know. Yeah. Okay.
Yeah, so the EPRF data from the ambulances as well as the coronial data is not in the IDI.
Right. Okay. Thank you very much.
Yeah, I actually know this is a major trauma registry, so it makes it a bit tricky.
Okay, great. Thank you, Gabriel. Right, the next presentation is online, hopefully. Here we are. Wonderful, wonderful. So here is today's Gontijo de Castro, and she's going to be talking to us about growth monitoring Aotearoa, scoping a national system for tamariki and rangatahi. All yours.
Kia ora, everyone. Thank you, Andrew, and thank you, everyone. And my apologies for not being able to be there today physically. I've been watching everything online. So today I would like to present a project where we aim to scope the creation of a national growth monitoring platform for tamariki and rangatahi in New Zealand. We are constituted by researchers from the University of Auckland, Otago University, Massa University, and Unipampa in Brazil. And the other investigators involved with this project are Professor Boyd Swinburne, Associate Professor Lisa Temorenga, Professor Rachel Taylor, Associate Professor Betty Muley, Dr. Arieli, and Leonardo Posa, Professor Leonardo Posa from Brazil. In New Zealand, childhood obesity is a huge public health problem. It affects 1 in each 3 children, and it has great ethnic disparities, with prevalence being 25% higher for Maori children and 100% higher for Pacific children in relation to non-Maori and non-Pacific children. However, the data that has been used to monitor healthy weight of 0 to 19-year-olds in New Zealand is overall fragmented, do not contain information for 0 to 2-year-olds, has big gaps for school-aged children, and mostly is data that is aggregated at the national level. Which means that currently New Zealand lacks group-specific information on prevalence, trends, and determinants of health weight of tamariki and rangatahi, which is basic data which is also essential to monitor progress on reducing unhealthy weight and inequities in unhealthy weight, identify areas and subpopulations of higher need or which could provide exemplars of interventions, provide the outcome evaluation data for population interventions or policies, and finally, to inform, shape, and catalyze regional actions to tackle unhealthy weight. So in this project, in this scoping project, we aim to map and to assess diverse anthropometric data sets of 0 to 19-year-olds in New Zealand to establish what would be required and which of these data sets would be suitable to be included in a national monitoring platform. Our intention is to assess data collected in the last 2 decades. It would include nationally representative or generalizable surveys or studies, including cross-sectional and cohort studies, regionally representative data, and data collected at the primary healthcare level. Specifically, we want to assess aspects of data anonymization and ethical implications to make this data available or in a platform, representativeness, coverage, frequency, year, the anthropometric measurements taken, the protocols used, as well as equipment used, some potential anthropometric data quality issues, as well as the potential requirements for harmonization of the data, aggregation level of the data, sampling processes, data storage, availability, and access, among other aspects. And finally, we also want to assess options to make this potential platform available to end users. Because we want to look to group-specific information, such as sociodemographic characteristics, age, and etc. So we are going to be also looking at the sociodemographic variables which were collected by these data sets to assess how their properties, as well as how comparable those variables are. Within the potential data sets that we classify as suitable to be included in this platform, we'll be also assessing the potential of using Bayesian hierarchical modeling approach or other statistical approach to modeling anthropometric data using surrounding dating time and population characteristics. The principles of the TTRT-OITAI will be also fully followed during all steps of this research, under guidance of associate professor. And this is a collaborative study, and we will be establishing two committees to guide our work we will be consulting with. So the first one is a national committee where you're going to be inviting stakeholders, researchers, and Maori representatives. And the international one, which will be constituted by experts in anthropometric monitoring platforms and in Bayesian statistics applied to anthropometric data.
Okay, 30 more seconds.
Okay, and so this is just the summary of the initial mapping of the anthropometric data sets that we intend to assess. And if you need more information on this project, please feel free to contact. My email address is there as well. And thank you very much for your attention.
Thank you, Teresa. Need to drive my phone. Right. Any questions for Teresa? So, Teresa, you've got lots of different data sets there. Are you going to be sort of mining the data for key variables and then aggregating it out in a separate environment, or how are you going to manage all those different sources of information?
Yes, Andrew, at the moment, it's going to be just a scoping study, the initial 2 years. When you get the funding, it's another point as well. Initially, I'm going to be looking separately to each of these data sets. And part of this project is exactly to understand which environment we could be using to collate this data and do this platform. So these are questions that we want to answer as well with this project. Yeah.
Please thank Teresa again.
Thank you.
Thank you. Right, next up we have Kevin. And Kevin Ross from Precision Driven Health is going to be talking about Precision Driven Health and how it's a partnership model for health data science.
Kia ora koutou. Thank you very much, Andrew. So I have this amazingly complex and exciting role, which is to lead a health data science partnership in New Zealand. When I took on this role, I thought it was, the most exciting role possible in New Zealand. The ingredients we have to do really good health data science are amazing in this place. We have good quality data, at least globally, relatively. We have data scientists in New Zealand that are known for producing great tools, sort of things like Weka and R that are, globally recognized tools for data science. But our academics hadn't really done that much application in the health domain for the real data science end of things. We have software companies like Orion Health that have a global reach. 100 million patients use software by New Zealand that are designed and built in New Zealand. And we have clinicians who are amazing at their roles and really interested in innovating. So the idea was to bring together a partnership and build health data science capability. When I realized, so this partnership started about 5 years ago, and when I started to bring these groups together, I realized that while each of these elements are really strong in and of themselves, everyone's a little bit suspicious of everyone else involved. So if you think of what software engineers and clinicians think of academics, they sort of see academics as doing interesting stuff that's over there, but it never really works in practice. It's all just theoretical. If you think of the software engineers and the academics' view of the clinicians, we've told you what you need to do, just either use the tools or follow the research and it should work. And why don't you just do that? And from the academic side and the clinical side, the idea of producing software tools and making money out of them sounds like it's pretty easy, but if you're successful, you're probably a little bit evil. But I want some of that money if you get some. And there's all this kind of weird kind of interplay between these different parties that you're trying to bring together into a partnership to genuinely work together. So it's a bigger challenge than perhaps might have been appreciated on sort of day one. But over that, over those 5 years, we've had about 100 projects. We've now had more than 50 students, more than 50 academics, more than 50 clinicians, and more than 50 commercial software engineers involved in our projects in that time. And if nothing else, we've had people work together and be exposed to what everyone else brings to those conversations. And all I want to do today is just talk about just some of the lessons learned from that general experience of bringing these groups together to produce these tools and processes. Our focus is really in the translation from data science into practice. And one of the things that we've really recognized is that great work happens that often doesn't get used. And so actually taking things through from the research says it would work to actually does it really work to it does really work is actually a really, really big challenge. All of the work that we do roughly fits under the banner of what I think of as this concept of people like you. So we're very familiar that data science has created, people like you watch this movie, or you usually drive this way home, or sort of some information about a person that leads to some advice that says we can give you better information. What better way to use that rather than try to sell you something out of that than to actually give you advice on how on your health outcomes. So people like you tend to experience these things in the next few years, or people like you are often prescribed this medication. There's all sorts of things that you can, at least in theory, do with data science and health that doesn't really happen in practice all that much, but it's definitely possible. And a lot of our work kind of fits around some of those areas. We work with a group called Te Whanau Aotearoa in West Auckland, and they are looking, they do a lot of broader services, not just health, but giving advice to whānau around particular times of need. And they are looking at the concept of whānau like you. What happens and what typically works for people in your sort of circumstance. And so you can imagine that sort of in that general concept, the idea of people like you could mean almost anything. So typically in health, we've thought of people with the same diagnosis. What are the outcomes like? But actually, it's much broader than that. It's people who have, have similar experience completely outside of the health sector tend to have similar outcomes within it. And so understanding what data actually has to come together to answer those questions is really broad and again, really complex. So really today, I just want to sort of emphasize that it's possible to do some really good work in this space. We're seeing, and you're going to hear a couple of the speakers later on talk about some of the project work that's come out of this partnership. We've got 2 years left to run on this partnership, and the partnership program doesn't exist anymore in New Zealand. So we are asking the question, what's the future of partnerships like this in the health data science space? We think there's a huge potential that we've only just scratched the surface of, and we really need to figure out how to share the tools that we're building with each other and to take them forward, not just to do great research, but to take that great research and lead to better outcomes for New Zealanders. Thank you very much.
Great, thank you, Kevin. Any questions for Kevin?
Go ahead. I can repeat it, yeah.
It's quite a big question, right? How do you navigate how people might not take well to data-driven decisions versus their intuitions as clinicians?
Yeah, it is a great question, and the answer is through partnership and collaboration. You have to involve people from the beginning of an idea through the design and go to the other end of it. I mean, there's all sorts of related questions in there. So when will you trust a machine? How much better than a person does it have to be? Is equal good enough? All those sorts of questions come into that. But at the end of the day, clinicians realize that they already use a lot of subjectivity, and sometimes you're not trying to replace them in the decision-making process. You're trying to potentially remove some of the biases that they know they probably have but don't have any tools to work with. So people like this often get prescribed this is a really interesting example because we know, for example, that Māori, typically get under-prescribed and under-referred. So the opportunity to use technology that's kind of based on the population, and again, what you'd like behaviour to be, not automating what's happened in the past, but with all that sort of nuance to it, the idea of giving someone a tool to help them make a better decision is attractive. They just want to do it within a really safe, well-designed environment. One more then. Yeah, so if you're in another parallel room, you'd be listening to Edmund Jang, who's talking about some of the free text work that we're doing. So the question was about free text for those online. So we're doing a lot of work in natural language processing. It started out as clinicians can't currently search records, so most of the data, about 80%, actually is unstructured. Literally, if you're a clinician and you want to read someone's history, you have to open one document at a time. Those referral letters that get sent around, they just get stored, and then Control F to find a key term. Not very efficient, potentially not very safe. So we've done a lot of work on trying to essentially tag and label those so that you can search over someone's record and use your own spelling mistakes and abbreviations to find similar terms, that sort of thing. And then obviously there's lots of other uses for that. And again, the concept of people like you includes people with language like is used about you in the referral letters. So that's sort of a general concept that we're exploring a lot. So glad to talk more about it offline, I think.
Next up we have Luke Boyle, and Luke is going to be talking to us about using risk-adjusted days alive and out of hospital to compare health outcomes across New Zealand after surgery.
So, let's just check it out. If you were going in for an operation tomorrow, would you be worried about dying? Probably not, and I'd hope not. In New Zealand, surgery is pretty safe. But most of the time, what we do to compare things is we look at mortality chance, and that's probably not very useful when most people don't die. I'm a PhD candidate at the University of Auckland. My PhD is funded through Precision-Driven Health that Kevin just mentioned before. And I'm looking at how we can use data to better understand surgery. I'm going to talk about a very small part of that today called days alive and out of hospital. So days alive and out of hospital, or DAO, is a kind of simple way to try and capture a complex series of events that might happen to someone. So the idea is you take a time period. We usually use 90 days. And for every day out of those 90 that you are in hospital or dead, you get like a -1. And then each person gets a score, and then those scores can be turned into distributions, and those distributions can tell you some interesting stories. The good thing about this is no matter what happens to you that might be bad, your score goes down. So it's pretty universal to understand, and also you can use it for different types of operations. So if you get an infection, you stay in hospital longer, it goes down. You go home, you come back and you readmit somewhere else, like even if it's somewhere else in the country, your score still goes down. You go home, stay home, then it looks really good. Here is what it looks like. So on your left, we have two distributions of DAO scores. So if the score is sort of pushed towards the 90, then that means that people are doing well, because most people are getting 90. And the black lines along the bottom are people who have died at certain points in the time period. So knowing that push to the right is better, you can look at the one below it and you can see that's worse. There's more black, so more people are dying, and also it's not as clustered towards the higher numbers. And what we can do with these is we can start to compare things. So in the other plot, I've got the shape of New Zealand roughly organized into DHBs, and then you go from dark to light means bad outcomes to good outcomes. So a distribution like that one on the top might be for Waimata, and it means that we're seeing all the patients do really well. Down the bottom, that distribution might be for Southland, and this is fudge data, so don't worry about Southland being bad or anything. And you can also use this to start talking to patients. So when I look at this distribution, I could say most patients are going to be home within 10 days and they're going to stay home. But 1 in 10 patients are going to be in hospital for almost 3 months. And that's information which is meaningful to patients rather than just telling them, like, you have a 7% chance of getting this infection over the next month while you're here or something. It's quite simple to understand. The innovation of the data is my work looking at risk adjusting this. So often risk adjustment is done on an individual basis. So if you take each person, you work out their weights based on something you know about them, and then you change their score. But because DAO has such weird distributions, that doesn't really work. And people end up with like -1 day in hospital, which doesn't make sense. So what we do is we use models to do risk adjustment. So you put as many things as you want into your model. You use that to predict what's going to happen to the people. And then you have a one-dimensional array of predictions, and those are used as weights. And those weights get used in the same way as like an age-based risk adjustment. So you have like age incidence of cancer. You could have like risk group 1 incidence of DAO. And that means that you pull the distributions up and down rather than moving them side to side, and you can adjust for things like the type of patients coming through. Once we do that, we can start looking at real information. So this is real information of DHBs for a particular operation. And the confidence intervals reflect the type of patients that are there, and you can see the average is coming up through the middle. The people in green are doing better than average for this operation after considering heaps of things about their patients, and the people in red are doing worse. This information is really important to places like the Ministry of Health, particularly as they start aggregating all the DHBs. And that's fine, I think. Cool. Questions? Good question. So are we looking at DHB of service or DHB of patient? The way that the data gets recorded in New Zealand is by where you live. So it's DHB of patient, which is kind of annoying, but it means that's really the only way we have access to the data. The other interesting side note to that is when you see missing DHBs in data sets, it's often international people because they don't have one recorded. Yeah. So follow up? Yeah. It's not in the data set, in the national minimum data set. We try not to adjust for DHBs if we're going to be comparing DHBs as well. And yeah. Yeah. No, so I think that's a bit of a sorry, so the question is, yeah, from about 2014, most, like above 95% of public and private report to the NMDS. Before that, then it's not as good with the private ones. But if you ever want to use the NMDS data, you can ask the ministry and they'll give you a list of the hospitals that didn't report for a particular day or a particular year. Yeah.
And in the risk adjustment, is that your sort of standard age, ethnicity, comorbidity?
Yeah, I guess I don't have much time to go into it here, but the benefit of this risk adjustment method that we're kind of trying to show for the first time is you can have as many things as you want. So you could throw 1,000 things into the model and you would then be risk adjusting the same way as if you only had one-dimensional data, which is quite powerful. So we're using the sort of standard things that we can get from the NMDS, but for my PhD work, this is kind of a case study of that method that can then be used later.
Thank you very much, Luke.
Thank you.
Okay, next up, we have a double header, which is being presented by Amanda Eng and Corbin, and it's on occupational exposures and ischemic heart disease, results from the entire New Zealand population using our friend, the Integrated Data Infrastructure. And they're both from the Research Centre for High Order and Health, Massey University, which is the renamed Centre for Public Health Research plus a bit, isn't it? Great. Welcome.
Thank you, Andrew. So, yeah, there are two abstracts in the program, but we're doing a joint presentation, which is not a cheeky way to get more time, but there are two sets of results from the same wider study, which looked at occupational risk factors for ischemic heart disease, results from the entire New Zealand population using the IDI and census. And just further to what Andrew said, we are now called the Research Centre for Hauora and Health, which used to be the Centre for Public Health Research and the Research Centre for Māori Health and Development. And in our haste, we forgot to add the co-investigators, but there is a wider team of researchers, including Steve Hazlitt from Massey and Rod Jackson from the University of Auckland. At RCHH, we are trying to explore how to use the IDI for our program of occupational health research. And so with this study, which looked at CVD, just a bit of background, CVD is a leading cause of death in most Western countries, including New Zealand, and work-related risk factors are often overlooked despite studies since the 50s showing associations with CVD. So we did three things. The first thing, which we're not going to talk about today, we did an ad hoc load. So we had 2 workforce surveys, one of the general population and one of the Māori population, and we loaded it into the IDI, and that had a wide range of exposure data. So that was the first thing we did. The second thing we did was look at occupation from the census and whether associations differed by sex and ethnicity. And the third thing we did was look at occupational exposures. And I don't know if a couple of weeks ago you saw there are quite a few headlines about long working hours increasing deaths from heart disease and stroke, which was a WHO ILO study. So it's been in the news recently.
So our study was a prospective cohort study that included all New Zealand residents aged between 20 and 64 years at the time of the 2013 census. So we looked at several exposures. So first, the occupation from the 2013 census, and then we looked at several other occupational exposures. The first one based on the census data, working hours, and then 3 other exposures, sedentary work, noise, and night shift, that we used by matching our job records to our 2 job exposure matrices, which are tools created by experts that link jobs and job exposures. And so then we looked at whether all these exposures were associated with IHD by using Cox proportional hazard regression models, and stratifying by sex and also by ethnicity when looking at occupation. So I mentioned in the previous slide that we used the census 2013 to build our cohort and also to get the occupation at baseline, and to match it with our job exposure matrices. So we also use other population data sources like border movements and death certificates in order to know whether people would die or move overseas during follow-up. And then in order to identify our IHD cases, we used 3 different health data sets that were mortality, pharmaceuticals, and publicly funded hospital discharges. So finally, as Amanda mentioned as well, we also uploaded those 2 New Zealand workforce surveys in order to link more specific occupational exposures to IHD, even though this time it wouldn't be based on the whole New Zealand population, but just on survey of people. So here are some results that we got for the first exposures, occupations. So the first table is basically showing the results, the risk for the big occupational groups that are defined by the New Zealand standard classification of occupations. So the risks that are highlighted in red are increased risk and statistically significant. And so we found increased risk for professionals, for service, for professional only for Maori males, for service and cell workers for non-Maori males and females, for plant machine operators and assemblers, for non-Maori males and females and for Maori females, and finally for elementary occupations for, from plant machine operators and assemblers only for non-Maori males, and finally for elementary occupations for non-Maori males, females, and for Maori females. We also looked at the literature and selected a list of occupations that had been found in previous study to be associated with increased risk of IHD. And from these occupations here are the ones that we also found associated with an increased risk of IHD in our study. So home helpers, cleaners, drivers, laborers, prison wardens, storekeepers, warehouse workers, and bakers. And we also looked at occupations that were not included in this list, and among them we also observed increased risk of IHD, such as for personal and protective service workers, but I'm not going to give an exhaustive list about it here because of the time limit.
So for the results for part 2, they were stratified by males and females, and these are the hazard ratios for the fully adjusted models with the covariates down the bottom. For sedentary and noise, the exposed categories are based on more than 50% of workers in those exposure categories. So just to reiterate, the working hours is a question from the census, but the bottom 3, sedentary, noise, and night shift, are the job exposure matrix tools that we developed to apply to the census. So just briefly, there's not a lot going on with working hours and sedentary, but we did find for the highest level of noise exposure, there was a modestly increased risk for males. And for both males and females, there was, again, a modest increased risk for night shift work and IHD. So just to summarise, I'm not sure how much time we've got. For part 1, 2 minutes. There were several occupations which have been identified at increased risk, including home helpers, cleaners, drivers, warehouse workers, personal and protective service workers, and the study also showed important differences between males and females and Māori and non-Māori. And then for part 2, night shift work was associated with IHD for both men and women, and there was a modest association for occupational exposure to high levels of noise for males. But the study did not support sedentary work or long working hours as risk factors for IHD. So thank you, that's our details there, and both results are close to submission for publication, and there's actually 3 papers from the ad hoc load part of the study as well. So yeah, we just wanted to provide an example of how we are trying to do occupational health research using the IDI, even though the type of occupational data in the IDI is quite limited. But yeah, thank you.
Thank you very much. We have time for some questions.
The question is, what would we like policymakers to take away from our results? So, as I mentioned at the beginning, occupational risk factors for IHD has seemed to have been overlooked despite studies since the 50s. I mean, the evidence is quite inconsistent. But yeah, would like to see, I guess, more attention paid to occupational risk factors for cardiovascular disease, whether that's from an epi perspective, but also maybe health promotion. And also, Marine's results showed that there were differences between men and women and Māori and non-Māori workers, so treating them the same wouldn't be an approach that we would recommend. that's a good question. The question was about Rod Jackson being a collaborator and whether this work could be incorporated in the primary care CVD risk work that he does. No, not at this stage. He's been advising on the definition of IHD created from the IDI, but yeah, that's an interesting point that we could raise with him. Thank you.
The penultimate talk today is about something that has kind of changed our lives over the last 18 months. So I'd like to invite Pieta Brown to come up and talking about sharing our experiences from COVID-19 and Te Pokapū Hatapi o Aotearoa, the New Zealand Algorithm Hub. Pieta from Orion Health. Thank you.
Kia ora koutou. I assume Andrew didn't mean the Algorithm Hub changed everyone's lives with COVID, but I am excited to talk to you today about our experiences with the Algorithm Hub. So I'm a product director at Orion Health, and we build health technology products mostly to support the integration and use of electronic health information. So what is the Algorithm Hub? Well, during New Zealand's response to COVID-19, it was clear that we needed a way to support people to easily access and use the best available tools and models and algorithms that were being developed by our amazing research community here, but also what was coming from overseas, because fortunately, you know, we didn't have a huge number of cases here, we didn't have widespread community transmission, and our healthcare sector wasn't being overloaded by cases. So a lot of these tools were being published overseas as well. And this was a 6-month initiative to deploy a local instance of some technology called the Machine Learning Manager. And this is tooling for deploying, governing, and managing algorithms. And it's agnostic, so cloud agnostic. It can also be deployed on-premise. And then wrapped around that, we created this Algorithm Hub solution. So it includes the content deployed on the technology platform. It included a governance process, and a lot of stakeholder engagement, as well as these different interaction channels. So what you can see here is the website. You're welcome to go and check this out at algorithmhub.co.nz. But one of the main use cases is actually that you can interact with all of these algorithms via API. So a clinical application can easily call these, or any other type of front-end system that someone might be developing can easily call these models and algorithms. So what are the benefits? We think there are some key benefits for different groups here. So for citizens, it ensures that decisions can be made with the support of the best available research toolkit, and that people aren't disadvantaged in areas where there might not be the same kind of in-house data science or research capability. For hospitals, clinicians, government planners and decision makers, it provides free and easy access to all of these tools, and it's an exciting opportunity to create a central shared knowledge base of these algorithms and models. And then for data scientists and researchers, what we hope this really does is shortcuts the path from research to reality, and it takes away a lot of the pain of deployment and sending code around or sending spreadsheets around, all of that maintenance, and frees up researchers to focus on what they do best, solving new problems and further developing models. What does it actually look like if you're calling a model via API? So this is just to make this a bit more concrete for some of the non-technical audience members. It might look something like this. So this is based on one of the models developed by Te Pūnaha Matatini, and this was an SEIR model for COVID-19 disease spread. So fortunately, there wasn't a lot of use of this type of model. This was if you had widespread community transmission. But what it looks like is that as a user, you can send in this set of parameter values, inputs based on the scenario or the situation that you want to model. The algorithm is run, and then the results are returned to you. And there's no data storage here. So that meant we could really accelerate deploying this to people and get it up and running quickly. A highlight was the development of the governance process. We were incredibly fortunate that this amazing team of experts in their respective fields came together to support this initiative. There's a lot of guidance out there on responsible AI and AI ethics, but when it came to evaluating kind of the nitty-gritty of a model for use in our context, we found that there was still quite a lot of work to do. And so we developed some of our own tools and templates, and you can find that template to download on the hub if you'd like to. So we used a multi-stage process here. We would shortlist an algorithm based on what's called a model card. So this was developed by Margaret Mitchell and others at Google, and it was a good way to help us prioritize some of these for review by the governance group. And then we would go through a detailed long-form document and really discuss questions related to each of these areas that you see listed there before a model would be endorsed and then deployed on the hub. And then we would let users know how they could access that, provide some sample guidance. Often that was in a Jupyter notebook, for example. And post-COVID, we've been getting some really interesting inquiries from people who would like to make their research available on the hub. So if you go there, you can see some new use cases being deployed that are now moving beyond the scope of our COVID-19 response. So if you'd like to get in touch, you can reach me at my email address or on Twitter. Thanks.
Any questions about the algorithm hub?
So all of the algorithms are freely available to call. In terms of the code, that's on our roadmap, how we make the code more transparent. But on the hub, there is documentation about every algorithm, what are the inputs, what are the outputs, and notes based on the governance discussions as well. Yeah, yeah. Cool. Thank you.
Last talk before, so I'm the only thing in between you and coffee, so I will be quick, right, hopefully. Thank you, all the speakers, for keeping on time. This last talk is about epidemiology for non-epidemiologists. For those of you who know me and keep seeing me in data environments, I've never done a stats paper in my entire life. I'm entirely self-taught, but I do teach official statistics and survey methods at postgraduate level at Auckland, which is all a bit weird. I'm a fluffy sociologist pretending to do epidemiology and occasionally hiding out in a stats department. But when I'm doing none of those things, I'm doing this. And this is creating tools for people to do and publish robust epidemiological analyses. My background was I started as the first Māori health research manager at the Health Research Council, and I had the benefit of working with two fantastic people, one called Edo Pomari and the other called Neil Pearce, and they were famous for doing a lot of work on inequalities in New Zealand. And one of the things that Neil used to do was these very long-winded age standardization methods for doing comparing population outcomes. And so I started doing that when Neil went to London. He handed the project over to me, and it was really, really tedious, right? And those of you who know me know that I'm not a details person, right? And so therefore it wasn't exactly robust. So and because I was getting really, really bored, because I've got the attention span of a gnat, we decided that we'd build something that did this automatically. And so we did a prototype for a summer student, and I gave it to him and thought, he'll never nail this. And 4 weeks into a 12-week summer studentship, he came back and said, actually, I think I've nailed it. I think I've got it. And it was pretty rough. In fact, it was extremely rough, but he had. And what we've done, Daniel and I have taken this and extended that, and we've created this tool called Mato, which with a macron means knowledge, without a macron it means fishhook. And what that enables you to do is anybody with a mouse and a computer interface can do really robust population outcome calculations and comparisons using pull-down menus. So there's everything's under the hood, and interactive graphics. So the graphics are interactive, they're not static. And what you enable, you select, it's going to go haywire on me. Right, okay, don't touch the buttons, Andrew. So you can select what your outcome of interest it is, the number of populations you want to compare, the year range, the age groups, and the aggregations that you use for precision, where you've actually, in order to deal with small n issues. And then there's a really wide range of epidemiological measures, some of which are really, really advanced. So we were actually ahead of the Ministry of Health by a long way in some of these methods here. So you can do internal, external standardisation. You can pick what external standard you want, which internal reference population you want to use, the confidence interval method, and your method of comparison. And it's all interactive. All the options are hidden down behind pull-down menus, and it defaults to the standard approach. And so if you don't touch anything, it just does the routine model. It's got multiple presentation pages and formats. So, and here's the summary page, and what that's got on is your total outcome over time, and the total mortality, the rate difference, and the rate ratio, because this is what we've selected as our comparators, all with confidence intervals. These are expandable and downloadable and flexible and interactive. So you click on that point, it'll tell you what the value is. And lots of different graphs, as you can see up the top. Everything is, so lots of different presentation pages and formats. Everything is downloadable. So there's multiple outcomes and geographies. We can do this, we've done it for Pacific Island data, we've done it for Australian data. We can do it for DHBs. Anything that we've got denominated data for, we can do it. We've also designed this to be capable for doing iwi-based data once they've got, if they load their own denominators or maps in it. And all of the output is exportable in terms of graphs, maps, or tables. So in tables, you can actually export the table and put it into your own visualization tool if you want. But we can also do comparisons between DHBs, and previously somebody said Southland wasn't actually all that bad, but I can tell you, if we're talking about amenable mortality in New Zealand, readily preventable death, then the West Coast is not the place to be. Okay, this work has not yet been published. It'll hopefully be published towards the end of the year, but that is the Māori, non-Māori comparison for readily preventable death in New Zealand. And the intent for doing this is not just to produce information for government. This will be public. So it's taking public domain information, like the NMHDS or the mortality collection, and putting it in a tool like this so you can't see the microdata anymore, but anybody with a mouse and 3 minutes to learn, the little training program, can learn how to drive this. So that's Mato. It is already live in terms of a research tool. It'll be live in terms of a product a little bit later in the year. We got somewhat delayed by the fact there was apparently a virus going around last year, and it kind of stuffed up abilities to travel and us getting money out of the Australians and things. The second is a similar tool, and this is a Shiny app, and what Daniel and I have been doing a lot of is using Shiny apps to visualize the impact of data change. Some of you may have heard of Te Mana Rauranga being highly critical with the results of the most recent census in terms of what it did for certain data types, especially Māori data and iwi data. And what we wanted to do is create a tool for looking at the impact of the changes in the data. And as a result of census 2018, they had to reconstruct the population from alternate data sources to fill in the gaps from the census. An amazing technical exercise, but what it has done is it resulted in a population that looks a little bit different. And it looks a little bit different both in terms of number and characteristics. So Daniel and I went, well, actually, how different is it? So what we did is we created a tool that anybody can use, and this will be public domain, and enables us to compare the impact of changing these population counts on our standard population health metrics. And in this instance, we've got mortality, we've got cancer, and we've got injury data. But what I can tell you from the early results from this is that when it graphs it, right, you can actually see that the population change is resulting from the new way of constructing a census population, and the estimated resident populations that come from it means that we've ended up in a really serious and significant break in the time trends for all of our historic comparators in population health between Māori and non-Māori. So there we are, 2 tools for easy and simple point-and-click visualizations and doing age standardization and looking at population health outcomes, one of which is flexible to multiple environments in terms of geography and health data, and one of specifically looking at different types of population denominator, which is going to be more important once we start getting to creating an administrative estimated resident population. So thanks very much. If you have if you want to get in contact, that's me, and that's my little company. But yes, I do use the Auckland University email because I've got a really, really, really good spam filter. So thanks very much. Any questions on? Yeah. So, yeah. Yep. Yeah, that's a low Māori population. Yeah. So and with this, so if you click on the graph, right, it'll show you the plots on here. If you click on the plots, it'll show you the graph. The graph is completely interactive. You can say show us the worst, show us the best, show us this outcome, this way of comparing it, that way of comparing it, and then it does this beautiful little thing which does compare DHBs, and it's savage. Great. Any other questions? Right, I won't keep you from coffee any longer. Thank you for being a wonderful audience, and thank you very much again to the speakers.